Good morning.
Good morning.
It's so nice to see so many familiar faces. My name is Sally Jakeway, and I am a speech language pathologist. Thank you for joining me this morning. Thank you. My goal this morning is to answer as best as I can, what is speech language pathology? This slide presentation was created with the help of Hannah Humphreys, who is the graduate clinician in speech pathology at the time. So what is speech language pathology? It is considered an allied health profession, and we work with people with motor speech disorders, swallowing disorders, problems with language processing, executive functioning skills, and voice. We collaborate closely with other allied fields, including physical therapy and occupational therapy, to create a comprehensive and patient-centered plan of care. So I wanted to first discuss some misconceptions about speech therapy. People often think that speech pathologists only work with articulation problems. While speech therapists do work in the schools, I will be talking from the point of view of a healthcare facility. But when I do approach a client for the first time who has had a medical setback, these are some of the more popular quotes I hear. I have no problem talking, or a spouse will say, she could talk your ear off. I've been talking all my life, and I don't need speech therapy. So it's a little bit more than just how a person speaks. So no PowerPoint presentation would be complete without a couple memes. I find this rather interesting. The first frame says, what my friends think I do, and that is a frame from the King's Speech. I do not work with royalty, but that would be fun. The second frame is what my mom thinks I do, and you see a woman with a lab coat and a stethoscope around her neck. Third frame is what society thinks I do. So that's what I was talking about regarding the misconceptions, working with children in articulation. While it is true that speech therapists work with that population, there are many other aspects to the profession. What my patients think I do. Now, that's not too far off. I do get to make faces with people, and then what I think I do. And then there is some truth to the very last frame, what I actually do, which is a pile of paperwork, and I think many of you here can relate to that. So some of the disorders that a speech pathologist might work with include aphasia, apraxia, cognitive communication disorder, dysarthria, dysphonia, dysphasia, and language comprehension and expression. Does anyone have any questions regarding those disorders? If any questions come up, just feel free to ask. So why would someone be referred to a speech language pathologist? Whenever someone's had a medical setback that changes their function, they might be referred to a speech pathologist, and that would include TBI and strokes. And we see a lot of language disorders as a result of brain injuries. Cancer, and that can be cancer of the head and neck, dementia, Parkinson's disease, and other progressive neurological conditions, neck trauma, conditions resulting in compromised respiratory functions, so that can include COPD, and heart disease. Changes in abilities following surgery. This is one area that people may not think a person would need speech therapists following surgery, but often there are changes in voice because of the intubation and extubation process. As well, when there is invasive heart surgery, it can damage the recurrent laryngeal nerve, which innervates the larynx and can result in changes in voice. Also, acute illness resulting in declines in functional abilities, and that can even be as common as a UTI, especially with our older population. It can really have some drastic effects on their cognition, and a speech pathologist might be called in just to help guide that person back to as close as to their skill level before. So Dysphasia. How can a speech therapist help with difficulty swallowing? We use evidence-based practices to strengthen the structures involved with swallowing. I am a certified vital stim provider, so when appropriate, I can provide vital stim. Teach and train compensatory strategies to enhance airway protection, and that can include body positioning. And there are some different ways a person can turn their head to help protect airway. We recommend diet textures and liquid consistencies to maximize nutritional intake and hydration. And one thing to keep in mind, a thicker liquid isn't always the safest for some people. People can still have dysphagia and actually be safer on a thin liquid. Communicate with a registered dietitian to decrease risk of malnutrition and dehydration. And this is very important, especially with our older population. We educate patient and family caregivers on recommendations as well as the associated risks. Again, there can be quite a learning curve for families who are having to carry over recommendations for diet texture and liquid consistencies following a hospital stay. We assess safety of oral intake following PEG tube placement, and we also collaborate with tracheostomy teams. Any questions so far? Okay. So in May of this year, the International Dysphagia Diet Standardization Initiative launched new parameters for the dysphagia diet. This looks very different than what most healthcare facilities are accustomed to, and it is not saying that they have to have all 8 levels, with thin being 0 and regular being 7, because most facilities will work within the soft bite size for food, regular and pureed, and then for liquids, the nectar, the honey, and sometimes the extremely thick, which would be like your pure pudding thick liquids. One of the first things I like to do when working with someone with swallowing problems is to review safe swallowing precautions. This can reduce the risk of choking and aspiration, and that would include recommend sitting upright, preferably in a chair as close to 90 degrees as possible for meals. Have meals in a low stim environment. Provide setup assistance as needed to enhance self-feeding. Alternate liquids and solids, and stay upright for at least 30 minutes following meals. This is hard to do sometimes in facilities, especially at breakfast time, because people tend to like to have breakfast in bed, and then what happens is they get real comfy and they start scooching down in bed. Before they know it, they're back asleep. Okay, so the speech therapy department has launched a restorative dining program, and this is offered Tuesdays and Thursdays during the lunch meal, 12 to 1. It is a low stim environment, and we have adaptive tools as needed for the residents in this dining room. It is supervised. Right now it's supervised by me and Hannah Humphrey. And our goal is to eventually train the nursing staff to carry this initiative forward. The room is also known as the employee lounge, so it's a small little room, but the nursing staff has been very kind to let us use this on Tuesdays and Thursdays. How can a speech therapist help with functional communication? So we help with motor speech. That includes articulation, how a person makes sounds, so we can help reteach a person how to place their oral motor structures to create the correct sounds. We cannot try to teach strategies to help a person self-advocate and be able to repair fluency breakdowns and be a better communicator, and teach strategies to achieve a natural prosodic features of speech, And that would include rate of speech, pitch variation, and voice loudness. We also work with people teaching and training augmentative and alternative communication devices. And on the right, you'll see 2 pictures of some high-tech and low-tech options. The picture on the lower right, you're probably very familiar with. A lot of facilities have that. And I do have copies of that communication board. So if anyone would like one at the end of this presentation, please feel free to grab one. So language skills refers to language processing and expression. So that is, how does a person understand language? Does that person use language in a social environment appropriately? Does that person know how to ask questions and respond to questions? Can a person show that they are taking turns in a conversation to move that conversation forward? Any questions about this?
Maybe my kids need speech.
Okay. So, as part of the therapy team, we talk about how safe a person is to go home. That's one of our very top goals. To address safety awareness, a speech pathologist will look at the underlying impairments. So, typically, it involves executive functioning skills. So that would include problem solving and memory, and those are all linked together in order for a person to be able to make good decisions and prioritize information. So how can I be of service? If anyone needs to find me, I am in patient room 4 across from the Doc Green's office. And I know it's a bit of a blurry picture, but that poster is on the wall right outside of my office, so you can look for that. And that poster was created by Hannah Humphreys. And also on the slide, you have my email and my own personal cell phone, because I love you all. Yes?
You can also tell them that even though those windows are black, doesn't mean you're not in there.
That is correct. Thank you, Miss Buzzer. So yes, always feel free to knock if the door's closed. So my direct employer is Provider Wellness Group, and Naveed Saad is here probably twice a week to meet up with me, and he's very accommodating and open to comments. So if anyone ever has any questions or comments, please, you can reach out to him directly. You can talk to me if you want to speak with him as well, but I typically touch base with him regularly. Here's a list of resources, including American Speech Language Association, the International Dysphasia Diet Standardization Initiative, and the Michigan Speech Language Hearing Association websites. They're all very wonderful resources and also have links to the political action committees, so you can read up what's being done in Washington.